Hello and welcome back. We will continue with our lecture on cervical screening. And in this part of the lecture, we will discuss about what happens if a patient has SIN 1 or SIN 2 or SIN 3, what are the possibilities. And then briefly, we will discuss about colposcopy, what are the indications, how it is performed, and maybe we will also cover a few slides about cervical cancer. So, once a patient is exposed to, say, for example, high-risk HPV, it takes many years to progress from one stage to another, especially SIN1, which is the very initial phase, right, precancerous stage. So the body's immune system, it automatically gets rid of it. Okay, so as a result, this is called low-grade lesion. Okay, but if it progresses to SIN2 or SIN3, from SIN2 onwards, it's called high-grade squamous intraepithelial lesions. Okay, so most of the low-grade lesions, they regress 60%. 30% can persist, and maybe 10% they can progress to the next stage, which is SIN2 or SIN3. Okay, so and it takes many years, and ultimately, if it is not treated SIN2 or SIN3, of course, it can progress to cancer of the cervix. Now, the high-grade lesions, which means SIN2 onwards, the regression rate, it's reduced, so 30%. It's actually the inverse of low-grade lesions. Regression is 30%, 60% is it can persist, and 10% to carcinoma. And again, it can take many years. Okay, now I know that I have just added this one. You're familiar with these kind of cytobrushes, but cytobrushes can also be like this. That's the reason why do they look different? Because this one, it's better to get a sample from the endocervical canal. Okay, especially in postmenopausal women, when there is the transformation zone, it goes back into the endocervical canal, so it may be difficult to get a sample from the transformation zone. So this one is actually very beneficial. Okay, and just as a revision, why this is like pointed, right? These cytobrushes. So this tip, it is to take sample from the endocervical canal, and this one from the external loss. Okay, so from the rest of the transformation zone. Okay, so now we will talk about what are the risk factors for cervical cancer. As we said earlier, cervical cancer is not genetic. Okay, the main risk is it's related to sexual practices, especially having multiple sexual partners. Okay, early age of first sexual intercourse, especially before the age of 18, or as the earlier it is, the higher risk the woman is at. And I'll come back to this last one. So the primary cause is basically persistence of infection with high risk HPV, and I asked you to remember just two, which are HPV 16 and 18. But of course, there are many HPV high risk types. And then other risk factors, for example, smoking, smoking cigarettes, right? And we know that there are two main types of cervical cancers. The majority are squamous cell carcinomas, and yeah, a few of them can be adenocarcinomas. Okay, so squamous cell carcinoma, for squamous cell carcinoma, cigarette smoking is a major risk factor. Weakened immune system, for example, if there is coexisting HIV, long-term use of oral contraceptives. So long-term, okay, but please remember that oral contraceptives, they protect against many cancers, especially ovarian cancer. Okay, so although in different research papers it's a bit controversial, but still long-term use of oral contraceptives can increase the risk of cervical cancer, especially in the presence of HPV, high-risk HPV infection, smoking. They can, and a decrease in immune system. For example, illness or chemotherapy, they are associated with an increased risk of precancerous or cervical intraepithelial neoplasia, changes in the cervix. Now, then it's also increased in daughters of women who took a medicine when they were pregnant. Now, this is a famous medicine. It's called diethyl silvestrol during pregnancy. I think it was given in 1960s to pregnant women to prevent against threatened miscarriage. Okay, So this medicine was given, but later on, if a woman was given, and then at that time, if she was pregnant with a female child, female baby, female fetus, that female fetus, when later on that baby was delivered, later on, it was discovered that many of these kids, girls, they had a lot of problems, like unusual things. For example, vaginal cancers. They were even increased risk of having anomalies in the genital tract, increased risk of having even ectopic pregnancies, a lot of things, right? So, daughters of women who took diethylstilbestrol during pregnancy, okay, they are at increased risk of having cervical cancer, okay? So, and then how can a woman present if there is cervical cancer? Remember, when we were discussing about abnormal uterine bleeding, we said every form of abnormal uterine bleeding, we always have to rule out one thing. For example, if it is postmenopausal bleeding, what do we have to rule out? Endometrial cancer. If it is postcoital bleeding, so if it's post-menopausal bleeding, we have to rule out endometrial cancer and endometrial hyperplasia. If it is post-coital bleeding, we have to rule out cervical pathology, which can be even SIN, which can be even sometimes it can be even cervical ectropion, right? Or sometimes maybe it can be even cervical cancer. So always rule out cervical pathology. There may be abnormal vaginal bleeding, abnormal vaginal discharge, okay? There may be dyspareunia, and if the cancer has spread, so of course there will be history of weight loss, there will be history of reduced appetite, but because very close to the cervix is the ureter, okay, so it's very close. So women can have urinary retention and renal failure, and in fact the most common cause of death in cervical cancer is uremia. Okay, so there may be even hydronephrosis if the ureter is blocked bilaterally. Okay, so there may be unilateral or bilateral, there may be hydronephrosis. So, see, when we discussed about this slide, I said do not remember the details, but it says in certain cases, colposcopy is indicated here. Colposcopy is indicated. What does colposcopy means? It means just simply a magnified view of the cervix. Do not confuse it with colonoscopy. Okay. So colposcopy is just it's a special device. It's uses spatial light and it magnifies. So it's a magnified view. But at the time of looking at the cervix, certain tests need to be done. Okay, first is just apply acetic acid. Okay, so it's in low resource countries where there is not the specific acetic acid preparation, simple vinegar can be used. Okay, because it's actually acetic acid, right? So and then if the areas are abnormal, the abnormal areas where there are precancerous or cancerous lesions, it turns white. Okay, and then iodine can be applied. That's Lugol's iodine. So why? I'll give you a reason. Okay. Now first, just let's discuss these Acetowhite changes. Okay. So if someone tells you on colposcopy, Acetowhite areas were seen, that's not a good thing. Okay, so acetowhite changes occur during colposcopy because a dilute acetic acid solution causes proteins in the epithelial cells to coagulate and become opaque, making abnormal areas stand out as white against the normal pink tissue. See, now this is a cervix, right? And this is the speculum. So this is the cervix, this is the os. You can see there is bleeding. Maybe it's bleed to touch. Bleed to touch means if we touch with, even while taking a cervical screening sample, it can bleed, or even when it touches the blades of the speculum. Okay, and see, there is this irregular. They must have applied acetic acid, and do you see there are these whitish patches, and actually they have highlighted it, right? They have pointed it out. So these are acetowhite areas. So then biopsy should be taken from here. Okay. Now, why iodine is used? Because normal cervical cells, they have a lot of glycogen. Okay, when you apply iodine to cells, they turn dark brown, very dark brown, okay, or close to blackish. So if there are abnormal cells, what happens? The precancerous or the cancerous cells, they have increased nutritional requirements, right? So they have depleted glycogen. Their glycogen levels are low in cancerous or precancerous cells. As a result, when we apply this Lugol's iodine, the abnormal cells, they will become yellowish or pale compared, they won't turn dark brown. Okay. For example, this one. Okay, so this was an Acetowhite area, right? You can clearly see this. So there are Acetowhite areas here, and when you apply Lugol's iodine, just see, compare this one, which is dark brown, which is the normal cells, and this, right? So just take a biopsy from here, any of these areas, from the Acetowhite areas, which is the same as when it turned pale. Okay. Now, what are some of the indications for colposcopy? There are many, as in the previous slide, but positive high risk HPV test with normal pap smear. So even if the pap smear is normal, but if there is high risk HPV test, okay, even if the pap smear is normal, is an indication for colposcopy to check for the presence of precancerous changes. And then if there is abnormal cytology test, for example, there are different types. Okay, one is called atypical squamous cells, where we cannot exclude high grade lesion, so it stands as H. Okay, so they're not sure whether there is high grade lesion or not, then there should be a colposcopy. Do not confuse this thing, ASCH, with, there is another very common condition which is called abnormal squamous cells of undetermined significance. It's instead of H, it's US. Okay, that's um, that's a common thing to appear on pap smear, but there is a certain algorithm we have to follow. Okay, and then atypical glandular cells. This is an indication for colposcopy, especially or if we see endometrial cells on a pap smear, that may be bad, especially in a postmenopausal woman. Endometrial cells, right, from the endometrium, we should not see in a postmenopausal woman. Or if it's a premenopausal woman, in the first 12 weeks of the cycle, that may be normal. Mostly that's normal, but after the 12 days, first 12 days of the menstrual cycle, we should not see abnormal endometrial cells. Endometrial cells on a pap smear. So that's why when we are sending a pap smear sample to the laboratory, we need to give them certain information. What is the age of the patient? Like, is she menopausal or postmenopausal, premenopausal or postmenopausal? That's very important for them. Even if she's pregnant or not, because in pregnancy there are certain changes, okay? And because of increased estrogen. And then what is the indication, right? Why are we doing? Is it a routine thing, or did she present with postcoital bleeding or something like that? When was her last menstrual period? It's very important, because if like, it's all a clinical picture, we need to know a clinical picture, and then we can interpret most of the investigations. Okay, then there may be high grade squamous intraepithelial lesion. Of course, this is like serious, right? So a colposcopy is indicated. And sometimes, when symptoms strongly suggestive of cervical cancer, such as abnormal vaginal bleeding or discharge. But just refer back to abnormal vaginal bleeding and discharge lecture, and then, so, okay, but just, you do not need to remember all of this. I'm referring you back to this slide, and it gives the indications for colposcopy. And here we discussed only a few of them. Okay, you do not need to remember the whole thing. Now, if there is a cancer, it's classified by FIGO. There are 4 stages as usual, and you can remember them for international exams. For this course, you do not need to. Okay, so it's a bit complicated, but you need to remember it for international exams. And now, this is again from the Ministry of Health guidelines. So, how urgently women need to see a doctor once, how frequently they should be followed up. If it's a high grade lesion, or abnormal squamous cells where high-grade lesion cannot be ruled out. It's urgent within 1 to 2 weeks. And if it's a low-grade lesion,